So the first part of this is just didactic, where I'm going to give some background and some intro. I think I know all of you, but and I'm so happy that each of you is here. Courtney, I want to introduce. Courtney has done peer support training for trainees, and has quite a bit of experience in doing that. We're trying to encourage more younger surgeons and even some trainees to do this training. And so Courtney's kind of my co-moderator, new member of the wellness committee, and I'm just really thrilled to have her here. Um, and I'm going to just jump into my slides, Tyrion. It's great to have you. And then when we do the role play breakout session part, it would be great to turn on screens if possible. Um, so hold on, let me just get to the beginning of my slides, and I'm going to move pretty quick because I really want to try to keep this to an hour. I know it's late on a Monday, but I want to make this worthwhile. And that we've done this quite a bit. And the feedback I always get is the most valuable part is the role play. So I really want to make sure we have time for that. Uh, Hold on. Why am I not able to? 1 second. Sorry, guys. My presentation just, we just practiced this. Um, Here. Are you guys seeing it? You're seeing not the,
Yep.
let me switch to presenter. Okay. So, all right. So quick. If you guys want, I know I saw a few other people have popped on. It's great to see you guys, Christine, Steve. Thank you so much for being here. I know some of you have done a lot of peer support training. Some of you, this is your first time. So we're trying to do this as a combined kind of refresher course and training. Um, if you in the chat can just type like where you work, what your role is. You don't have to say too much about what you're hoping to gain unless you want to. And then does your organization have a formal peer support program? If you know, if you guys just want to kind of introduce each other in the chat so people who don't know each other can just have some background. I'm gonna give a little bit of background about kind of what is peer support, how does it help us get into the nuts and bolts of the peer support encounter. And I hope to do all that in 25 minutes. So promptly at 7:30, somebody like give me a signal if I'm getting to 7:30 and we're not close to the role play. Um, and then just leave 5 minutes at the end for a debrief or a wrap up. And Courtney, I had introduced earlier as my co-moderator for those of you who weren't on. So Courtney, if you keep an eye on the chat and just let me know if anyone has questions or anything, or feel free to just speak up. We're in a small group. Um, so just kind of setting the stage here, these are pictures I took off of various children's hospital websites, and it really depicts, I think, what we love about our job, which is making children better, and helping families through what's often one of the most challenging experiences of their lives when their child is sick or having surgery. Um, and so when we think about that, I mean, we all know why we went into this field, but then you couple that with the fact that, every single year there is a full medical school worth of physicians who commit suicide. This is also, if we look at other healthcare professions like nursing, the suicide rates are much higher. And I think this is sort of the underside. We all love to talk about why we love our jobs, but it's kind of two sides of the same coin where like the highs are really high and the lows are really low. And we all struggle when our patients don't do well. And that's why we're here tonight. So, burnout has been described since the early 2000s. This was kind of the early hallmark publication in surgery describing the incidence of burnout among American surgeons, and it was characterized as emotional exhaustion and depersonalization. Um, and what this graph is showing is when you have committed an error in the last 3 months, you have a much higher rate of burnout, and medical errors are associated with burnout. And what we've learned as we've studied this is that when you have made a medical error and then this causes burnout, and when you are burned out, you are more likely to make an error. So it kind of creates this vicious cycle, and can lead to people leaving medicine or potentially even committing suicide. So there was a huge survey done across the United States and Canada about the emotional impact of a medical error. And what this survey showed is that about 90% of physicians who responded to the survey said that they had committed a medical error, and over 90% said that they had no support from their institution in the wake of an error. So this is an extremely lonely experience. We also know that errors correlate with suicidal ideation. And what is going on here? Well, I think I'll just say this is a controversial term. The term second victim was coined back in 2000. This was the original publication. There have been patient advocacy groups that have taken issue with this term because they do not like to think of a healthcare provider as a victim when a patient is the one who was harmed. I don't think we have a good alternative term for it, and I think having a language to talk about it is so important. So I do still use the term, but I acknowledge the controversy. So this describes a scenario which is probably familiar to many of us. When I was a house officer, a resident failed to identify EKG signs of tamponade that would rush the patient back to the operating room. The news spread rapidly. The case tried repeatedly before an incredulous jury of peers who returned a summary judgment of incompetence. I was dismayed by the lack of sympathy and wondered if I could have made the same mistake and, like the resident, become the second victim of the error. This rang so true to me. I feel like in my training experience and also even as an attending, I feel like we jump to judgment and we really feel like it could have happened to anyone. So the definition of a second victim is a healthcare provider involved in an unanticipated adverse occurrence. So it doesn't have to be an error. Sometimes our patient doesn't do well, and it has nothing that anyone did wrong. They just don't do well, and that can also create the same syndrome. So it's experiencing psychological and emotional trauma related to an adverse patient outcome. I'm not going to read through all these boxes, but I think these probably sound very familiar to many of you, whether you've experienced them personally or talked with colleagues who have experienced these feelings. And when we surveyed our membership of APSA and we asked about personal experience committing a medical error that resulted in harm or death, 80% of us said that we had personally committed a medical error that resulted in patient harm or death at varying time points over the career. But this is really, really common. Not everybody who has a patient who doesn't do well or who has a patient where they made an error experiences second victim syndrome. This has been studied, and there are certain high-risk groups, and I've highlighted the ones that we interact with in our day-to-day lives. So we have a lot of risk factors, being surgeons, being providers who treat children, trainees are at high risk. And if we have a case that involves a special connection with the family. So I think there's a lot of risk factors particular to pediatric surgery. We asked in our survey, who would you want to be contacted by after an adverse event? And I think a lot of us think that people don't want to talk about it, but in fact, only about 11% of us said that we wouldn't want to be contacted by anyone. And that's how we phrased it. We didn't say, like, who would you initiate a conversation with? We said, who would you want to be contacted by? Because we're not good, when we are the ones suffering, we're not good at expressing that or asking for help. So I think one of my big take-home messages today is, like, don't wait for someone to come to you. If you think someone is struggling, please talk to them about it. Um, Most of us said that we wanted to be contacted by other surgeons in our practice, close to 80%, or other physician colleagues. And there was some interest in an institutional peer support program. This was before we started our APSA peer support program, 40%. So the trajectory of what happens after medical error has been studied, as I mentioned, in the work that's been done by Susan Scott, who is a nurse, who is a PhD, who devoted much of her career to studying the second victim syndrome and its trajectory. And what she described is, after a medical error or an adverse event, one of three things can happen. We can recover and we can thrive and come back even stronger than we were before. We can sort of just push it down and away from our conscious mind, because we're really good at doing that as surgeons, and just kind of go into survival mode where we're going to work, we're taking care of patients on the outside. No one thinks anything is wrong, but we're actually not really okay. I think that's probably the most common reaction, or the dropping out, leaving medicine altogether, or even worse. And I think peer support is a mechanism that can help kind of shunt us to the thriving stage of this possible pathway, where, as opposed to surviving or dropping out. So that's really the argument I'm trying to make today. I think when yep. Sorry, did someone say something? Sorry, thought I heard something. So I think for those of us who've experienced a bad complication and have felt second victim syndrome, what happens, or seen a colleague going through it, you can't see yourself outside of this keyhole. you think about this recent terrible event and it defines you. And I think the peer support encounter helps kind of like bring you out of this keyhole and normalizes this reaction and helps you kind of understand and move past it. Um, and I think I really think this is helpful because a lot of the time, the left column is what we're thinking, and then the right column is what the second victim is thinking. We think like he wants some time to process everything and he's feeling isolated and alone. We think, well, we should lessen her caseload, and she interprets that as having lost confidence in her abilities. We're thinking, well, I just don't know what to say. They just want to be treated normally. I don't want to make her relive the situation, but actually, she's constantly reliving the situation. You bringing it up and talking to her about it is not going to make her think about something that she's not already thinking about constantly. So, again, my big message after this is use these skills and always reach out. Okay, that was my background. We're on time so far. And please feel free to like ask questions or interrupt me at any point if I'm going too quickly. Um, so I'm gonna kind of go into the nuts and bolts of how we do. This is how we do our peer support training at Nemours, and I think it's a really useful framework. I don't think you have to follow these steps to a T, but it just gives you some framework. I've talked with some of you, and you've told me like I knew my colleagues were suffering, but I just didn't know what to say to them, and this is kind of hopefully going to give you those tools to have these conversations. Um, so it's really important just up front to think about like what is peer support and what it's not. I think this was one of the hardest things for me to learn to do as a peer supporter. We are surgeons. We like to fix problems. We like to figure it out, make the diagnosis, make the solution, and move on. And you can see a lot of these things in this right-hand column. Like this is not about cheering up and reassuring and just moving on. This is about like witnessing their feelings, sitting with the suffering, tolerating the distress, and feeling comfortable with that. So I think that's like the most important message. You guys can read through these other things on the screen about what it is and what it is not, but I think it's very different than like the therapeutic encounters we're used to. And it's just being there and listening and normalizing for the most part. I'm going to play this quick video, and this is from Inside Out, part one. It's a great movie. They released a sequel. I highly recommend it if you haven't seen it. And this is joy and this is sadness, and they're with their elephant friend. I think his name is Bongo, and something really terrible just happened. So as you're watching this, I want you to think about who is providing better peer support. Is it joy or is it sadness?
My rocket! Wait, Riley and I were still using that rocket. It still has some song power left. Who's your friend who likes to play? No, you can't take my rocket to the top. Riley and I are going to the moon. Riley can't be done with me.
Hey, it's gonna be okay. We can fix this. We just need to get back to headquarters. Which way to the train station?
I had a whole trip planned for us.
Hey, who's ticklish, huh? Here comes the tickle monster.
I'm sorry they took your rocket. They took something that you loved. It's gone. Forever.
Sadness. Don't make him feel worse.
Sorry.
It's all I had left of Riley.
I bet you and Riley had great adventures.
Oh, they were wonderful. Once we flew back in time. We had breakfast twice that day.
Sadness.
That sounds amazing. I bet Riley liked it.
Oh, she did. We were best friends.
Yeah, it's sad.
I'm okay now. Come on. The train station is this way.
So anyone yell out your thoughts on who's providing better peer support? Type it in the chat, whatever you feel like.
Sadness.
Yeah, thank you. So this video was really like transformational for me. I watched it after I'd already been doing peer support for a while, and I realized I was totally Joy and I was doing it all wrong. So I feel I channel this sadness character a lot when I'm doing peer support because it definitely goes like against my nature. Um, so yeah, so like just acknowledging the feelings, letting the person express the feelings, normalizing them, naming them. It's sad, right? We tell when we act this way, we communicate it's okay and it's normal to feel sad and I'm here for you. Versus when we focus on fixing it and moving on to the next thing or distracting, we're communicating, don't be sad because I'm uncomfortable with you sad and I just want you to get over it. So channeling this sadness, I think, is really important. Um, this is kind of more of the same concept. Like we shouldn't be fixing it. We shouldn't be analyzing it or telling them what they did or didn't do wrong. Um, we don't want to give pity or sympathy. We don't want to just say like, "Oh, chin up, you're a great doctor." We don't want to distract. We don't want to interrogate them, right? We just want to be a supportive presence. And I'm going to talk more about what we should do. When we do our training at No More's, we break it down into these four stages: the introduction, exploration, normalizing, and follow-up. And I'm just going to briefly go through each of these phases before we go into your breakout sessions to practice. So during the introduction, it's really just about kind of making a connection and explaining why you're reaching out to them. Sometimes someone might have self-referred and then they know. Sometimes you're approaching them because of a referral they may not know about. So there's a different nuance to that conversation. I think in the common scenario of one of your partners had a bad day in the OR, you can just go to them and, we all hear about these significant complications when they happen. Or maybe you had a really difficult discussion at M&M. Say like, it sounds like you had a rough day. Do you want to talk about it? And that's all you need to do for an opening. The next stage, once you've kind of introduced yourself and set the stage for the encounter, is to explore. Just active listening. Just let them talk. Try not to even interrupt them and just let them, like if you're just silent, a lot of the time it opens the door for them to express their feelings. Um, Trying not to focus on the details of what happened, but just like how they're doing with what happened. And some techniques, which we just saw sadness demonstrating, just kind of summarizing what they said, labeling their feelings. You sound like you're sad. You sound like you're frustrated. You sound just naming helps people feel heard and not that you have to fix it. And even just saying things like, tell me more about that. What did that feel like? Just these very open-ended kind of probing questions, not having to like go to a solution, but just exploring their feelings. And here are some quotes like restating like you're wondering what might happen. Do you think people might judge you? It sounds like you're worried about just getting through the next few days. It sounds like you're worried about how you're going to feel when you have that same case again. And just kind of really summarizing what they're saying, and then that lets them know that you're hearing them. Um, Labeling, these are just some synonyms for some of the feelings that people tend to express. And again, just naming those feelings and labeling them can feel very supportive. Some examples. And then again, the open-ended about, how, tell me about this. You want to try not to ask why questions because that can sound like it's judgmental, and just letting the answers come as they come. And then I think the normalizing is a really important thing. And I think that's especially what we are equipped to do very well when it's someone that we know and it's a complication that we might have even experienced ourselves. Um, just really reassuring them that their reaction and their emotions are normal. If you have had a similar experience, it might be appropriate to share it. Um, when I face something like that, I felt like this. I've been there. Would you like to know what helped me? I think for surgeons, especially when they hear that like you've had a similar complication, I think that is hugely helpful because they don't feel like it's just them. Um, And then the follow-up. Are you sleeping? Are you eating? What have you done like this if something like this has happened to you in the past, what has helped you? Knowing what are the resources that are available in your local environments. Most hospitals do have some kind of employee assistance program. It might be helpful for them to talk to someone or just to at least know how to connect them if they're interested in that. Who will be their support person at home? And what do you need from them? as I mentioned before, like what has gotten you through similar challenges in the past. And then I'll often at the end of the conversation say, you know, what the resources might be that I could connect them with. And then I'm going to check in again. And I do check in at least one more time after the initial encounter. This is peer support is not meant to be like an enduring multiple encounters, but I usually do check in at least once after the initial conversation. This is a video that I'm not going to watch now or play now, but Kurt Heiss and Matt Clifton acted out a peer support encounter after a surgeon placed a fictional scenario where a surgeon placed a trocar into the aorta. And I think they really nicely demonstrate the different stages. And if you're interested in just sort of watching an encounter for the full thing, you can look at this video, but I'm not going to play it right now because of timing. Oops. And then it always like accidentally opens it. Sorry. Okay. All right. Before we talk about the breakouts, I'm going to spend a minute talking about discoverability. So when when there is a significant adverse event, a lot of the time there is a lawsuit. A question sometimes comes up, um, is the peer support encounter protected? And it's not, because we're not in a therapeutic relationship. We are not providing mental health counseling. So theoretically, if anyone has ever been sued, one of the first things people ask you is who did you talk to about the case? So theoretically, if someone was asked that and you had provided peer support for them, they might say, well, I talked to Lauren Berman. She provided peer support after this terrible thing happened. And theoretically, I could get subpoenaed. Um, as far as we know, Joe Shapiro is really the main thought leader, I would say, in this space. She's helped hundreds of institutions establish peer support programs. She helped us at APSA establish our initial program and did our initial training. She's not aware of any case where a peer supporter has actually been subpoenaed. The other thing is, even if you are, you're not taking notes on the details. Um, the thought that you'd have anything that would actually be useful to, a plaintiff's attorney in a malpractice suit, it's just extremely unlikely. It is discoverable, but I don't want any of you to feel like that's a barrier to providing support. And I also don't want you to feel, one of the things we talk about is like, oh, shy them away from the details of the case. I find a lot of surgeons want to share the details. And then I made this incision, and then this happened, so I decided to do that. And maybe I should have done this. And I think it's really important to let them say all that. And if they're looking for your kind of opinion on it, not to hold back from giving that. Um, Not to like make the whole thing about that, but sometimes that's what is healing for us, just to be able to talk about those details and say them out loud. So I don't want this discoverability issue to be on anyone's mind as a barrier to providing support. And I think that's one of the really important take homes of this. Does anyone have questions about that? Okay.
Lauren, I think you emphasize appropriately what it isn't. And it isn't psychotherapy and it isn't an M&M.
Yes.
And because one, we're not trained to do the psychotherapy, and two, you don't want it to be M&M because that's not what you're there for. So that's why the discoverability portion is probably as low risk as possible. And we did have one of our own colleagues, Mark Hoffman, who is a pediatric surgeon and then became a malpractice attorney for the plaintiff side, has, agreed with Joe Shapiro that there's very, very little value to a plaintiff's attorney to subpoena a peer supporter who talked about emotions. So I think that's one worry you should not have.
Thank you, Steve. Yeah, I totally agree. I think it comes up a lot sometimes in these training sessions, and people are very worried about it. The way I look at it is like, okay, I get subpoenaed. Like it's stressful to get subpoenaed, even if you're not the, primary subject of the lawsuit. But like, I think very quickly they're going to realize that you do not have anything. Like, did you talk to Dr. So and so? Yes. Were they upset? Yes. Of course they're upset. Something bad happened. It doesn't mean they did something wrong. You don't so I don't think we would have sufficient details that would be helpful. Um, but it is important to know that it technically you could be subpoenaed. Okay. Um, so any other questions before we talk about the breakout sessions? And I think we're actually like right on time. So you're in your groups of four, you're going to have two pairs, just kind of randomly pick. And
My
um, in your pair, one of you, you're going to spend like, this is quick. So you're going to spend like 4 minutes being the peer supporter, and then you're going to switch roles, and you're going to have a real quick debrief. And then you're going to, and so two people will be doing the peer support, and then two people will just be observing. Um, and then Marina's going to keep sending like prompts for you to switch. Um, and for this, we really like to have videos on. If you are just in the observer role, you're not one of the either the person giving or receiving support, you can turn your video off. Um, and basically, there's going to be someone receiving support and someone giving support. And we're going to just do 4 minutes each to kind of keep to the time. And then we're going to switch. And then the second pair will go. So it'll be like 4 minutes of giving support, 4 minutes of receiving support, 4 minutes of feedback. And then we switch and then we do the same thing for giving, for receiving, for feedback. So the whole thing should take like less than a half an hour. Marina, did I get that right with your prompts? And Courtney and I
Yes,
will
I
be in the
think so.
rooms with you, kind of helping you along. Um, and we don't have to do all the feedback in the small groups because we're going to come back to the main room and also kind of like share feedback and reflections. Um, so I want you to start thinking about like what is a story I could tell to receive support. You could talk about an event that happened to you. We would want it to be like something a little bit stressful, but not like really, really hard, like a 5 out of 10, not a 10 out of 10. And just try to put yourself back into the moment of when this thing happened to you. Um, and so in like one sentence, if you're the person who starts off at receiving support, you just say like, here's what happened to me. If you'd prefer not to do anything personal, we are giving you a case example that you can use when you're receiving support. And you can just say, I have a patient who has a similar medical history as one of my family members, and I've been really distracted and irritable over the last few days, and I'm dreading going to work because of the stress and worry I feel when I'm caring for this patient. So that's just like a generic example that if you don't have a good one at the top of your mind that you want to receive support on, you could just use this example. And then this is just a quick reminder, you do not have to stick to the script, but just the general approach. You introduce yourself, you explore feelings, you restate their thoughts, you label the feelings, you deepen the inquiry, you normalize it, and then you make a plan for follow-up. So I know that's a lot to get through in 4 minutes, and don't worry about following this exactly. Um, but here's the edited slides with the 4 minutes. Does that make sense, Courtney? Do you understand? Because you and I can each be in one of the rooms and then we can help move them along.
Yep, that sounds perfect.
Okay. Anyone else have questions? I'm going to just stop sharing. Marina's going to start putting people into rooms and then we'll get going and my hope is like to be wrapping this up around like 5 of 8 because I do want to share just like some quick resources and some information about the APSA program specifically at the end. I think everyone's just trickling back in and we do want to just spend a couple minutes. I know I don't want anyone to give like personal feedback, like when this person did that, that felt bad. But if anyone has a reflection to share of how it felt, either providing support or receiving support in those breakouts or something you learned or something that was surprising, I would love to hear any kind of general feedback reflections before we do our wrap up. Or Courtney or Sarah, if you guys as moderators have something. Oh, nicely done. Good for you, Sarah. That's good. You did it better moderating than I did.
We
And
kind of hustled through.
one thing we talked about in our group a lot was that I think people did a really good job of was letting the person who's giving the scenario or the supportee really talk. All of the people in our group did a really lovely job of just letting them go. And we talked about how sometimes that can be the start of the therapeutic benefit of peer support is just feeling like you can go for as long as you need to go to really describe the scenario, and then by doing that, your how you're feeling, how you're processing it kind of comes out in that as well. And
Mhm.
so I thought our group did a really nice job with that.
Yep. Just not saying anything and just being there is so helpful. Like more than, and I hope that you felt that when you were the one receiving support, just being able to talk and express. And then I think in my group, they did a really good job of just like the naming and the labeling of feelings. And when you label it and they're like, oh yeah, they understand that I feel that way. Then it encourages them to keep talking. So. Um, any other like comments or reflections,
I thought
questions?
in our group that there there was no it didn't, it was nothing like an M&M. There was no questions about the case or what you could have done, or it was all just focused on letting the person talk, and uh, then asking them about their feelings, and then one of the people in our group was good enough to label things, and so I thought it was exactly what it was supposed to be. I thought I was impressed, because it's not. I was mentioning, as a typically the first thing you do is like you see one of your partners, and then you kind of, it's kind of both. It's kind of like you feel bad, you share your own story, and then you talk more about it, but it's not it's not as strictly just the feelings like this.
Right.
So
Thanks, Sam.
And one thing that was another thing that was brought up in my group is how it may actually be easier to talk about it when you're talking with someone who's not in your division or someone that you know, because you feel like you can maybe be a little bit more vulnerable and share things because you don't work with them, you don't really have the direct effects. So if you're sharing something like, I feel nervous about doing this procedure again because of this happening, that may not be something that you want to admit to people in your division, and talking to someone you don't know may make you feel more free to talk about those feelings.
Yep. No, that's a great point. All right. I just want to make sure all of you are aware of the program for APSA and kind of how to access it, because any of you, if you are interested in becoming a peer supporter officially and having your name listed on the website as a part of the drop-down menu, you are welcome to. You don't have to at all, but just something to think about. I think there's a huge role for this, as Courtney was just saying, sometimes it's just better to talk to someone outside the group, and there can be many reasons for that. But I really do hope that you can take away from this a feeling of like, I'm going to go back, and when the next time there's a really tough M&M case or fill in the blank, I'm just going to reach out and say, how are you doing? And they may say fine, and they may not want to talk, but just making that reach out, I think, can make a huge difference in changing the culture so that we normalize it. Thank you, Marina. So Marina just put in the chat. Um, Let me just take 1 minute if I can. Um, I'm not even going to try to go to the presenter view because I keep screwing up and for some reason it's not going to the current slide. Um, so this is the website that it takes you to. Marina just put the link in the chat. This is the referral form. And you put the information of the person that you're referring. And it tells you like if it's a self-referral or a non-self referral, what is the reason for referral, and then here's the drop-down menu I was talking about. So if you would like to be listed, then just let us know and we can update the website. When we receive a referral, we do try to match that person with someone who's similar in terms of their years in practice. We want to have trainees talking to trainees or early career surgeons, and same senior surgeons talking to more senior surgeons. Um, and then if you want kind of more of a refresher on the didactics, because I did rush through it, we have recorded 3 APSisodes that is a little bit more of an extended version of the training that we just did. and they each are introduced by a vignette, a very personal story from these senior APSA members. So I really would highly encourage you to watch these, share them, etc. And then this is a great video of, I'm not going to show it now because we don't have time, but Dr. Glaucomflecken does a peer support encounter and he really like nails it. It's like this busy surgeon and he just shows like how even with the busy surgeon persona, you can kind of like have a conversation and he kind of goes through all the stages of the peer support encounter in a very quick and kind of humorous way. So I really enjoyed that video. Um, so with that, I will wrap it up. And I think just like this slide of the role that each of you can play, I think I skipped over that in the beginning. Like this is really, really important just to always reach out or make sure someone is reaching out if one of your partners was involved in an adverse event, even if they seem like they're totally fine, because we're so good at seeming fine when we're actually not. Um, and that reach out can make all the difference. And I think we and our partners that we work with, we're in kind of a unique position to reaffirm their confidence, not in a way to say like, oh, you're a great surgeon, you'll be fine, because that's not really what they want to hear, but just to kind of like quietly and slowly help them kind of rehabilitate by letting them know that you have faith in them and you trust them. So I think these local examples are really important. So I'm gonna stop sharing. It's not too bad, only 8:05. Any last questions or thoughts or comments before we wrap things up? Thanks, Marina. Yeah, we did consolidate all the resources. So if you just keep scrolling down the peer support page, you get to those episodes. And I saw several of you in the comment did say you want to be listed, and that's great. We can do that, but you don't need to respond right now, or you can think about it. It's not a huge burden. We get one referral like every few months. But it's nice to just have a large group to choose from because we sometimes get people sort of at unique career stages or in certain geographies. So um, we like to have a big list of supporters. Okay. Well, thank you guys so much for being here. Thank you to Courtney and Sarah for moderating. And Marina, thank you so much for helping us organize and administer everything. So feel free to reach out to me with any other thoughts, comments, questions, etc. And everybody has a great rest of your evening.
Thank you. And thank you, Lauren, for organizing this again and doing this is awesome.
Thank
Yeah,
you.
thanks, Lauren. Thanks, guys.
Thank
Thank you
you.
so
Have a good night,
much.
y'all. Bye.
Take
Have a
care.
good night, everyone. Thanks, Lauren, for doing this again.